thank you guys for coming. I didn't realize when I rescheduled the lecture that this is right after OCAP.
Probably.
And I thought because OCAP during my time, sounds so old, was sort of second or third week in April. And I guess they've shifted that now, which was right before Easter for you guys. So it wasn't very fair either. Okay.
There's a whole reason behind that is that because now since it's computer-based, there are only certain weekends that the prometric centers can accommodate that, and they basically told us, like, you cannot do it at all in April and or May, and so that starts pushing you into March, and they don't want to do it earlier in March because that's when, you know, a lot of other things are going on.
Other testing materials, yeah. All right, guys. Well, thank you again for coming. And, well, hopefully, since you guys already took the OCAP, we're just going to fly by all the questions here because you're going to know all the answers. Everything is still fresh. So I had a lot to cover, actually, in this lecture, and it's all about conjunctivitis. And we have the infectious kind, so I'm going to go through bacterial, viral, the ophthalmic kind, and granulomatous. We're going to do immune-mediated conjunctivitis as well, allergic, vernal, atopic, contact lens-induced, and ligneous. We're going to talk about SLK as well at the end, and that's kind of like in its own little category. All right, so I started off with basic concept slides, even though these are very, very beginners sort of, but they're very important to address all conjunctivitis. You always want to be able, when you're looking at a red eye, is evaluate what you're looking at. And I mean, really half the game is evaluating what you have and then coming up with a differential when you mix it in with the history. So here on the right, who wants to tell me and describe what they see up there on the right-hand side? Just call it out.
Up on the right, It looks like follicles.
So up on the right, there is a velvety, I'll tell you, the pictures again, we can't zoom in here, right? The pictures here, it's a velvety appearance.
Sorry.
Upper right, sorry, and upper left that way. Oh, yeah, you're right. You're right, they're follicles. Okay. So follicles are on this side, and these are actually, when you find them in the, so we'll start off with the papillae on this side. Let's go over to the left. The papillary reaction that you see in conjunctivitis is usually, they're elevated fibrovascular changes in the conjunctiva. Now, the conjunctiva is anchored down, right, to the tarsus over here and here in this picture here. And these diagrams are all coming out of your basic sciences books. And you have dilated capillaries. They sort of are spoke-like in nature, and they have all these inflammatory cells. And mixed with that, you get a lot of lid swelling and edema, and they form these polygonal shapes in the tarsus. And you can have a whole range of them from mild to large. And then the other side, on the right side, am I saying that right? Yes. You have the follicles, which are round oval clusters, and they are usually full of lymphocytes. And they usually appear like this, just sort of elevated round clusters. In this is benign folliculosis. You're going to see follicles normally in the lateral area of the conjunctiva in kids and adolescents. And that's a normal finding. All right, guys, so first question. Follicular conjunctivitis is associated with all the following conditions except, is it herpes, adult inclusion conjunctivitis, drug-induced conjunctivitis, or allergic conjunctivitis?
Allergic.
You got it, because you're going to see a papillary. All the other ones, herpes, molluscum, all of those are going to show adult inclusion conjunctivitis, drug-induced toxic, so any drops are all going to be follicular conjunctivitis. All right, so what's the differential diagnosis of an acute follicular conjunctivitis? Anything under 4 weeks. Anyone know? Just anything? EKC, good. Adenovirus. We had herpes. Hemorrhagic conjunctivitis, which, I didn't see much of that ever tested on, but I've seen it in clinic almost a handful of times now, in private practice, and it's pretty impressive to see someone walking with bilateral hemorrhagic conjunctivitis, and it's usually in a teenager or young adult. Chlamydia in Newcastle, which, again, not very common viral conjunctivitis. All right. So the differential of more than 4 weeks of a chronic follicular conjunctivitis we're going to go through is paranoids, oculoglandular. You got the toxic kind, again, atropine, brimonidine. A lot of drops can cause a toxic conjunctivitis. Trachoma, which usually affects upper or lower? You got it, upper molluscum, and Moraxella, which is correlated with blepharitis, and you got Lyme on there too, as well as chlamydia. All the bottom ones are, Lyme is not that common. Okay, so an intense inflammatory reaction can also cause another clinical entity known as membranes and pseudomembranes. So who can tell me the difference between a membrane and a pseudomembrane?
Well, it's supposed to be whether it bleeds, but they all bleed, I feel like, so.
They do.
Pseudomembrane's not supposed to bleed, technically, when you pull it off.
Right, and do you know why? Theoretically, you get bleeding with a true membrane is because when you have severe inflammation, you get coagulation of the exudate within the epithelium, so that when you remove the membrane, the true membrane, you're actually removing epithelium as well. Whereas in a pseudomembrane, all of the coagulation of exudate is occurring on top of the epithelium, so the epithelium is intact when you peel it off. All right, so then we go through a little differential here of membranes and pseudomembranes. The ones that are in yellow, I basically just highlighted because those are the ones that we'll talk about to some detail here. And the other ones I think are going to be covered in your other lectures. So again, this one is just a little mnemonic, and maybe you guys can help me out, but it's A, B, C, D. You see A through I to sort of remember. So you got the adenovirus, beta hemolytic strep, chemical or chlamydial. Erythema multiforme was an E because I couldn't get SJS in there. This is Stevens-Johnson syndrome, but it'll help you remember that. Foreign bodies can give you membranes and pseudomembranes. You got gonococcal, HSV, and immune-related, again, meaning pemphigoid, vernal, and then those VPL I really couldn't fit into that little mnemonic. We'll figure that one out later. Okay, so a lot of times membranes can cause a lot of scarring as well under conjunctiva, and it leads to cicatricial changes. So that's another way to describe, what kind of conjunctivitis do you have. And you see this a lot in Stevens-Johnson's, inflammatory conditions, and pemphigoid. And usually you see this inferior shortening of the fornix. You get some blepharon formation. You can also get scarring from even atopic disease and trachoma. And trachoma has a type of cicatrizing conjunctivitis. The Art's line is that subepithelial fibrosis that we see on the upper tarsus, and Herbert's pits are also cicatricial limbal follicles. So those are all different ways to describe these. And then lastly, we have granulomatous, and you can see that in sarcoid or routine foreign bodies. Again, I'm not going to be talking about sarcoid in this lecture, but we will touch on Parinaud's oculoglandular syndrome. All right. So we're just going to start off with a few pictures every now and then just to sort of see what you guys see. This is just an external photograph. What can you describe, and what do you see?
So it looks like we're looking at an external photograph of the eyelids. It's focused mainly on the crusting and, blepharitis appearance to the base of the lashes, the collarettes.
Exactly. You got collarettes, you got flakes there. And what types are there of, you would call this blepharitis? What types are there?
There's an anterior blepharitis, there's a posterior blepharitis. There's like an angular blepharitis.
Very nice. That's my next slide. Perfect. So we got infectious, inflammatory, and if you're talking about the anterior lid, you're usually describing an infection with, it's usually staphylococcal in origin. If it's posterior lid, it's usually meibomian gland dysfunction. And then you also have seborrheic. Let's not forget seborrheic, chronic abnormally oily secretions in the anterior lid. Okay, and you know that with blepharitis, everybody comes in with a blepharoconjunctivitis, and they have a red eye, and it persists for 4 weeks, and they say they have some crusting in the morning, and they have some discomfort and burning in their eyes. And just sort of to know that with chronic conjunctivitis, you also have to think about the lids causing the problem. And it's usually Staph aureus, and again, you have crusts, punctate epithelial erosions, you got infiltrates and flectenules on the cornea. And then, like you said, in Moraxella, you have a chronic angular blepharitis, which is if you look at the lateral canthus, you have a little fissuring of the, and the lateral fissure, you have some crusting and excoriation of the eyelid. One thing to note is that when you have a chronic unilateral conjunctivitis and you've been treating it, with steroids and antibiotics, and in an older individual, you always have to think about a masquerade syndrome. So always keep that in mind whenever you're looking at a unilateral.
Of that on the test.
Was there really?
Who had like 6 months of lid scrubs and lid hygiene, and he had like matarosis and he had sebaceous.
Sebaceous, yeah. That's the one you got to think about.
His eyelid.
Good, you guys all got that one. All right.
Yep, we got that.
So what else can you get with blepharitis? So keratitis as well, and that's going to be, again, you're going to have lid margin disease along with punctate epithelial erosions, marginal infiltrates, and flectinulosis. All right, so that's it for the blepharitis, and I'm going to sort of go through these pretty quickly with you guys, and we're moving on to infections of the conjunctiva now. And what's your diagnosis here? Or at least what can you describe here in the picture?
So, external photograph, the lid margins don't look too bad. There's some staining of the pool at the edge of the lashes, but it doesn't look, the lid margins are normal thickness. There's no loss of lashes. Your attention is drawn instantly to the conjunctiva, where there looks to be probably a membrane or pseudomembrane, and it looks like there's some hemorrhagic areas of, to me it looks probably follicular with intervening hemorrhages, but
that's pretty good. You can see all of that from there. But I certainly, right here, usually when they show you photographs, they're always showing you sort of like right smack in the center what they want you to see. And this is just exudative. You see a lot of conjunctival injection. Like you said, it's difficult to tell what the lid is doing here. But this is typical if someone comes in, and you have some kind of suppurative discharge. You're thinking bacterial conjunctivitis, right? So I know that it's more common in kids than in adults. We know that it's a result of overgrowth. It's usually that either kids, picking their noses or just sort of, just not overall being clean. They have direct contact with secretions and things. Sorry, kids. They get all of these things. So that's why it's more common in kids than in adults. But it's usually self-limited. It's rarely sight or life-threatening. And usually the onset and severity suggests the etiology. So usually it's less than 3 weeks, right? They're complaining, hey, but every week I have this discharge. It's yellow. And you got to think about the most common organisms, and it's strep pneumo, Staph aureus, and H. flu. You don't really need to culture these because you usually just treat them with some kind of antibiotic. But you want to culture people who are compromised hosts, so any HIV, any patients receiving chemo, in severe cases, and then obviously in cases that don't respond to any kind of antibiotic therapy. So the treatment, some advocate no treatment at all because if it looks okay, it's self-limiting, it's going to get better on its own. Or maybe it looks a little viral and you're not really sure. No one's ever going to fault you for not treating it at all at first and waiting, for things to evolve. But usually you want to pick anything like ILO, bacitracin, polytrim, any of the fluoroquinolones. And I say that H. flu is sensitive to polytrim. Polytrim seems to be an overall good drop for any of these. Sometimes you have to treat systemically, like if a patient comes in and they have a conjunctivitis and they also have a pharyngitis, then you kind of want to also treat systemically to get rid of all of the symptoms. And in children, they say that you may want to treat as well. All right, and this one,
so gross.
Yeah. It is. And you hope when you see this that you're wearing gloves. But what do you see here?
Yeah. It's everywhere.
Did you guys see this also?
There was a question, what's the most common STD in the country?
Oh.
Chlamydia versus
We think it's chlamydia.
I think it's chlamydia.
Good.
They had actually 2 questions about neonatal. I think you.
Oh, good. We'll go into that. Sure. Okay. Good. You guys can tell me about that. But this one here is you guys have a lot of edema, discharge. Exactly. So hyperacute purulent conjunctivitis, less than 24 hours, usually young, probably male, who comes in complaining about, sudden onset of redness, pain, swelling, discharge, maybe blurred vision. Your usual suspect is gonococcal. You have an explosive onset of this conjunctivitis with massive edge exudation. Keratitis does occur quite frequently, 15 to 40%, so you always want to make sure that you're looking at the cornea and making sure that you treat that accordingly because it is a very rapid progression into perforation and loss of vision, okay? Gonorrhea does affect the cornea. So what organisms? 2 main ones.
Gonorrhea.
So Neisseria gonorrhea and
Chlamydia.
Neisseria meningitis is the second one, the 2 of those. And transmission, 3 main ways. That's it. I should have that on the slide, a little sound effect. But yes, genital eye, genital hand-eye, and maternal fetal during vaginal delivery. Especially if there was rupture of membranes, you have to suspect it. Okay, so what do you see in the gram stain?
Gram-negative with diplococcus.
You got it. All right. Very good. So management, this is all, again, from your BCS, sort of the criteria, how you're going to treat this. If the cornea is not involved, they're saying you can just give an IM dose of ceftriaxone, and I believe that had been in my OCAPs as well, or azithromycin. And they find that azithromycin 1 gram dose also is not only good against penicillin-resistant Neisseria gonorrhea, but also good for treating chlamydia. So if you're suspecting gonorrhea, if you have gonorrhea diagnosis, you're going to suspect chlamydia. If the cornea is involved, again, because of rapid progression to corneal perforation, you want to admit these patients. You want to start them on ceftriaxone 1 gram Q12 hours for 3 days. If any of them have a penicillin allergy, spectomycin or Cipro can help. And you want to, if they're in the hospital, you want to frequently irrigate to remove any of the inflammatory mediators. And you want to treat with topical ointments, antibacterial ointments. Again, treat for chlamydia because a third of them have a concurrent infection, and you would do either doxy or azithromycin. All right, speaking of chlamydia.
All over it. Yeah.
Anything else on that?
They just talked about in children, they had like several neonatal questions. Yeah, but it basically, I think what they were getting at is that you need to treat them orally. Yep. All the time.
With chlamydia or gonorrhea?
Chlamydia.
With chlamydia,
yeah.
right.
Yeah.
Absolutely. And do you know why?
Because they can have the lung involvement and all of that. So
right.
I think, but the choices they gave were not, like tetracycline was one of the options, which you're never going to give to like a baby, you know.
It's erythromycin,
yeah.
PO, yeah. Okay, so again, going into chlamydia, actually, that's a hint. What do you see on the pictures here?
You're getting some scarring of the like one of those little Arlt's lines.
Right. Arch line over here. You got it. And how about over here? What is this? Lower tarsus and fornix. These are actually supposed to be little follicles. They're raised, inflamed. You see them there? Well, so again, what organisms? You know, there are basically 3 subtypes of chlamydia, right? There is trachoma, adult inclusion, which also includes the neonatal inclusion, and you have lymphoma, granuloma, something like that. Anyhow, so and with those subtypes, you also have all of the other serotypes that are involved. And again, these are sort of testable questions when they ask you, well, which serotypes are involved in trachoma. But trachoma happens in communities where there's poor hygiene and inadequate sanitation. It's pretty endemic in the Middle East, and you can see on the map here where in Africa it's also endemic. About 150 million people are affected worldwide, so it's the leading cause of preventable blindness. The most common way to transmit this is eye to eye, but they've also seen that houseflies and fomites such as doorknobs, toys, and all of that can actually transmit it because they're vectors. You get conjunctival follicles and necrosis, and they cause scarring, like we said, in Art's line. You get the superior tarsus and Herbert's pits, which are depressions at the limbus of necrosed limbal tissue, follicles. So here's just a picture of Herbert's pits. Can you guys see that? You've got those round depressions all around the limbus here. Once you see it, you'll never forget it. And those are involuted necrosed limbal follicles. All right. Corneal findings are going to be keratitis, stromal infiltrates. You can get fibrovascular pannus. Do you know where that is? Superior, inferior? It's mostly superior. The clinical diagnosis requires 2 of those because this is not, something that we often biopsy or test for in trachoma. But you need 2 of the following: conjunctival follicles on the upper tarsus, limbal follicles, and Herbert's pits. You can get, if you find Art's line, that's another criteria, and vascular pannus at the superior limbus. The scarring can result in long-term consequences like aqueous tear deficiency, tear drainage obstruction. You can get trichiasis, so you can see these people often even on follow-up after the initial event with trichiasis and entropion, in which case you want to epilate and you want to repair the entropion. The World Health Organization came up with this classification mainly for non-ophthalmologists. They wanted a quick way to sort of survey the people, and any healthcare workers that are involved in these countries who are reporting on trachoma. And so they have just all these 5 stages. Honestly, I've never seen this tested on, but you should know that it sort of varies from a grading system of very mild follicular conjunctivitis to intense, then involving tarsus, trichiasis, and corneal opacification. So you just need to know this. And then you have the treatment options. If it's active, you want to treat them with azithromycin PO and topical erythromycin. If you want to treat the complications, like we said, ablation and surgery for entropion. Moving on to adult inclusion conjunctivitis, which is serotypes D through K. These are sexually transmitted, but there have been reports that they can come about in inadequate chlorinated pools and sharing eye makeup, which is kind of scary. But, you know, if someone ever denies a sexual history, like young kids, you know, that you're seeing and you're sure they're 12 years old and, you know, you've asked them and they're not sexually active, give them the benefit of the doubt because there might be some other kind of transmission that they might have been, it might have occurred. The onset is usually 1 to 2 weeks, but it can be weeks to months. You get a follicular response, like I said, over here, lower eyelid in adult inclusion conjunctivitis as opposed to trachoma, which was superior lid. And you can see them on the bulbar conj and the semilunar folds. Very little discharge with these. It's really just going to be a diagnosis where you see all these follicles and just chronic conjunctivitis, and you can have finer coarse epithelial infiltrates and subepithelial infiltrates and micropanis. The management, you know, these actually can resolve spontaneously 6 to 18 months, but it's important to treat them because you also want to treat their systemic problem and you want to treat the partners as well. Neonatal, moving on, and then you guys can tell me if this was on there, but neonatal, do you guys know why there's no follicular response? It's papillary.
Probably because their immune system isn't, yeah.
Exactly. They haven't built any lymphocytes as a neonate, which is less than 1 month. So there's not going to be a follicular response. They're different from adult inclusion conjunctivitis because there's a lot more mucopurulent discharge. You get more membranes, and more commonly the cultures are positive, and you find intracytoplasmic inclusions. And they're more likely to respond to topical medications. Erythromycin ointment usually is what you use for that. And we already talked about that, but what other chlamydial-associated conditions can they have?
You have a long pneumonitis.
Pneumonitis and otitis media are the two main ones, so you want to treat those. Topical erythromycin and erythromycin PO for 2 weeks, or IV, sorry. Okay, so here's another picture, again, moving on to the neonates. And bacterial conjunctivitis. It's a 1 week old. What do you think can cause this?
Herpes strep causes.
H flu.
There you go. So we have chlamydia on the top of it, right? Because we said that was pretty common. But Streptococcus viridans, Staph aureus, H flu, Group D strep, Marxella, E. coli, other gram-negative ROBs. But the one at the bottom, Neisseria gonorrhea, is not as common. It's very rare. Less than 1% is what's quoted, but it's the most severe form. So you absolutely want to be able to diagnose this one. And again, especially if the history is vaginal delivery, rupture of membranes, this is top of the list, okay? Okay, so I am missing one slide, but that's okay. All right, let's move on to other types of infections of the conjunctiva. And again, this is just a picture here of follicles in the inferior. But what else do you see here?
STIs.
Subepithelial infiltrates, right. Very coarse punctate epithelial erosions on the left. And so what strains, what is this?
Adenovirus.
Adeno, and which type? Well, EKC, I don't know that you need to know the strains, but there you are. So adenoviral keratoconjunctivitis can cause a great big broad spectrum of disease. So you have people who are very mild and very severe, and it's transmitted by close contact with secretions, contaminated objects or solutions. You've got the subgroups, A through F. There's a ton of serotypes. And then the syndromes that, your book highlights mainly is simple follicular conjunctivitis with many serotypes, pharyngoconjunctival fever, which is adenovirus types 3 and subgroup 3 and 7, and then EKC, which is 8, 19, 37, and subgroup D. So you guys know that the patient comes in with a follicular response. It's usually self-limited. Tears, supportive care, and they don't really have to be treated with anything else. If they have pharyngoconjunctival keratoconjunctivitis, they have a fever, they present with headache, pharyngitis, the follicular conjunctivitis, preauricular adenopathy. Usually a lot of patients come in and they've been sick or they've had sick contacts. There's a 7 to 10 day incubation period, and it's bilateral in the majority, or it starts off in one eye and then goes on to the next. You can feel for preauricular nodes, and you can have severe follicular conjunctivitis with hemorrhages, maybe some membranes, some epithelial defects. They say that they're infectious for about 7 to 10 days. So sometimes when people say, well, what can I go back to work? And usually want them to have a resolution of their symptoms so that they're not infectious. But a lot of people say about 10 days is a good time from the onset. Again, clinical diagnosis of a follicular conjunctivitis, you need supportive management. You want to offer them cold compresses, artificial tears. If there are membranes, you might want to remove them and give them some steroids as well. But steroids, there's a little controversy as to when you would start steroids and why, because they feel that it may prolong viral shedding. So a lot of times you may start steroids on them because they're very uncomfortable and you're looking at them and they look uncomfortable, or their vision is also affected. Otherwise, they come in, it's just a little itching, a little tearing, then I probably wouldn't go ahead with steroids. But you want to tell them that they have to be very careful at home, frequent hand washing, we all know that. Stay out of school. All right, which of the following viruses is transmissible even after medical instrumentation is cleaned with alcohol? Exactly, talking about adeno, right? And the reason that is because the other viruses are all enveloped eye viruses. So they have a lipid bilayer that's very permeable to UV light, detergents, alcohol. So all of those actually, the minute they're exposed to air, usually don't survive. But adeno doesn't have an envelope, and therefore it's very strong against any of the detergents. So they say that if you, let's say you check with the tonometer, with the applanation tonometer, that tip should be in hydrogen peroxide for several hours and or bleach for about 10 minutes. Okay, so what do you see here, guys?
Bilateral hemorrhagic.
And what causes this?
Well, it could be.
Adeno and one more.
There's like...
Oh, there's 3. Enterovirus, Coxsackie, and adeno. So several viruses can cause an acute hemorrhagic conjunctivitis. And bilateral, a lot of times they just come in, it's bilateral, just started. They're not in a lot of discomfort, and they haven't been in any trauma, obviously. And so that's your diagnosis. And the management is just supportive. Again, their vision is usually is rarely affected. Okay, what do we see here?
Molluscum.
You got it. And what about it? Why is it molluscum?
Just it's sort of like a little bit of like a white core kind of appearance, elevated focal.
Umbilicated. Yeah, this was a girl who came in. She was 7 years old in beauty pageants already. And she had been treated for a chronic conjunctivitis for almost a year. I mean, they had her on allergic meds, on antibiotic stuff. And really, it was just on the eyelid right there. And she had noticed it had gotten a little bit bigger over the last few months, but no one had really made the diagnosis that her chronic conjunctivitis was from this molluscum lesion. So it's spread by direct contact. You got the umbilical nodules, which release viral particles into the tear film, causing follicular conjunctivitis. And you find them on the lid. And the diagnosis?
On the oak.
What causes the conjunctivitis?
Viral
shedding.
Viral shedding. Okay. You know what else they've shown is the path slide, and that's why I included it here. I've seen the path slide as well, shown for molluscum, and those are, the path slide usually shows acanthosis and all of these molluscum bodies here, which they were calling Henderson-Patterson in the past. I think they're just calling them molluscum bodies nowadays. A lot of these you can just observe and they will resolve, but if they're causing discomfort or red eye in a child, then you want to take it out. And a lot of times you just do simple excision. Some people say, plus minus the cryotherapy. Okay, here's another one. Conjunctivitis, red eye. What do you see?
It looks like a focal kind of white nodule with surrounding hyperemia.
Exactly. So gelatinous is the way they describe this, granulomatous lesion. And what kind of questions do you want to ask? Granulomatous conjunctivitis.
I would do a thorough review of systems, probably just to make sure there's nothing going on systemically. Is it painful? How long has it been there? Those kind of, any trauma to the area? Because I actually have seen a kid who shoved something under their conjunctiva.
Yeah, foreign body can definitely cause this, but you're right, systemic questions, ruling out sarcoid, TB, all those. But in here, this one is really leading into cat scratch disease. So you want to know if they've been exposed to any cats, if they've been scratched. It's a granulomatous conjunctivitis, sometimes related with lymphadenopathy, and affects 22,000 people annually. So it's not that common, but yet it is, you can see it in children. The main player here is Bartonella Hensley, and there are all these other types that were highlighted in the BCS, Aphipia fellis, which actually was first described to be Bartonella, but and it was actually described by the AFIP. That's why it's called Aphipia. Where did they come up with that name, right? But it was a team of doctors from the AFIP. But later on, they concluded that it was actually the same type as Bartonella Hensley. Anyhow, other types of Bartonella, tularemia, so you want to ask if they've been exposed to rodents, rabbits, right? TB, if they've been traveling. Sporotrichosis, so and Rose Gardner syndrome, people who've been out gardening can develop this granulomatous infection, and coccidioidomycosis, valley fever. Okay, so you want to ask about if any cat scratches. A bite or even a licking can cause this 3 to 10 days after inoculation, and it causes a unilateral conjunctival granuloma. Again, I keep repeating that just sort of so it stays. And then they can have lymph node involvement as well at the same time. It's very rare that they're going to have any disseminated complications, but they can have encephalopathy, encephalitis, hepatitis, osteolysis, optic neuritis, and even neuroretinitis. We know that from, and I'm sure neuroretinitis has shown up on many of those OCAB questions over the years. All right, so how do you diagnose cat scratch disease? Antibodies to B. Hensley. It's very, easy to do, and it's the most definitive, and you want to treat them accordingly. There are different treatment options. A lot of times people say rifampin or just azithromycin, but I would actually consult ID on that one, especially if it's a child. Okay, moving on here. We are moving on to the immune-mediated conjunctivitis. So this is a 20-year-old, comes in itching, tearing, both eyes, has a watery, teary eye with conjunctival injection, and you want to think about immune-mediated. It's bilateral usually, anything like hay fever, could it be vernal, atopic, ligneous, or contact lens-induced?
There was an atopic question on the test.
Was there?
It was like year-round erythema, small papillae, a PSC cataract.
PSC, yeah, with atopic, you got it. So the pathogenesis, we know it's IgE-mediated, immediate hypersensitivity. An allergen is usually airborne. It's very difficult sometimes with these patients. It's easy to treat them. You can just, give them an antihistamine. But sometimes it's hard to tell what they're being exposed to that's the allergen. Is it at work environment? Is it at home? Is it a new pet? Is it old carpets? A lot of things that can make this worse and come back pretty frequently. You want to tell them not to scratch because that releases mast cells and releases more histamine. And they usually do suffer from other atopic conditions, and again, the hallmark is itching. If they're complaining of any itching, it's usually an allergic conjunctivitis, lydedema, conjunctival redness, chemosis. They can have a ropey discharge, whitish discharge. Contact lenses, it's important and can facilitate this because a lot of people who are in extended wear or contact lenses that are monthlies or so, they just sort of keep putting the same allergen back in their eye. So it's important to know if they're a contact lens wearer that maybe they need to be soaking their contact lenses in hydrogen peroxide or in or changing to dailies. Let's see. So laboratory findings, that's usually a clinical diagnosis, but if you were to scrape the conjunctiva, you would find eosinophils. And a lot of times you want to send these people to an allergist if you can't get them under control. So you want to avoid the allergen. You want them to clean or change their old carpets, their linens, their bedding. Cold compresses help with the symptoms. Artificial tears that help to dilute and flush the allergens. And we talked about topical antihistamines and mast cell stabilizers. There's a bunch of them. NSAIDs sometimes can also help, especially long-term. Steroids for just a short burst, usually. Topical cyclosporin has also helped in allergic conjunctivitis. And vasoconstrictors, not a lot of people are advocates of the vasoconstrictors because they only should be used for a couple of days. They do cause a tachyphylaxis of it, and then they result in, increasing in red eye after. And you want to refer them to an allergist. Okay, more pictures. This is a 14-year-old boy here who came in. What does he have? Or what do you see?
He's got, it looks like a thickened, just kind of nasty-looking, superficial tarsus. I mean, that looks really gross. This
is from like across the door. You can see it as if you flip his eyelid, and actually it's just a picture taken with an iPhone. It's giant papillae, and you get this sort of discharge that right in the furrows too, because these polygonal sort of shapes of the papillae have deep furrows, and so they get all this ropey stuff that kind of just gets stuck in there, that mucus. And then something else that you see with this type of conjunctivitis, vernal, is a shield ulcer, and that's what you see here on the cornea. So usually these are recurring. They may persist year-round. It's bilateral inflammation. It's more common in male kids than in female children. Usually there's a personal family history of atopy. You get both type 1 and 4 hypersensitivity reactions. And presentation is common: itching, blepharospasm, photophobia. Kids are uncomfortable by this. Blurred vision as well. Kids can come in with like 20/40, 20/30 vision. It's not a lot, but still they're not 20/20. And copious mucoid discharge. And there are two types of vernal keratoconjunctivitis. You've got the palpebral type, which is diffuse papillary hypertrophy on the upper region. As a GPC, you get bulbar redness and chemosis. And then there's the limbal type. And these are really cool to see sometimes too, because the limbus is very thickened and has a gelatinous appearance around it. And these are also Horner's Trantas dots, which are aggregates of degenerate eosinophils and epithelial cells. Most common limbal is in African and Asian descent and in hotter climates. I remember that being in my OCAP, limbal in African descent. And here we go. These are Horner Trantas dots, again, just sort of around the limbus, this thick gelatinous mounds that come about. And these actually respond very nicely to steroids. The minute you hit them hard with steroids, like within a day or two, they're symptomatically, they're much improved also. Corneal changes. You can get, obviously, some PEE in the central and superior cornea. You can get pannus. More commonly, you see shield ulcers, which are non-infectious epithelial ulcers with underlying stromal opacification. So again, you have a kid with this sort of giant papillary conjunctivitis, and then they also show up with corneal findings. And it's a male child. You pretty much know it's vernal. Management depends on the severity, so you're going to start treating with antihistamines initially. If it comes in looking like, with those Herbert Trantas pits, you want to definitely treat them with mast cell stabilizers and even steroids. You want to do pulse therapy, so you want to put them in high dose and a quick taper, maybe a week or two, and that's it. Sometimes for kids that keep coming back with this and they've been on steroids and you've tapered them off, and you may want to add restasis to that. It's plus minus, but they say that also helps. Very rarely. I've never seen supratarsal injection of steroids, but that's also, I guess, another type of treatment. 1/3 of them have, okay, sorry, how did I skip? So let's see. Let's go to this slide. Let's talk about atopic keratoconjunctivitis. And the presentation is very similar to vernal, only that these patients are older. So you have an older male or female. The disease is year-round. They have a papillary reaction, milky conjunctival edema with subepithelial fibrosis. They have corneal neovascularization, opacification, secondary to chronic epithelial disease. And they may end up atopic and scar, so it can definitely lead to limbal stem cell deficiency as well, and a cicatricial conjunctivitis. 1/3 of them have dermatitis as well, and these are all signs of type 1 hypersensitivity. There's a depressed systemic cell-mediated immunity and type 4 hypersensitivity. So again, type 1 and type 4 as in vernal. And eosinophils, though, are less numerous. You can get conjunctival scarring, like we said, and then you've already answered this. What type of cataract do you see with AKC? And that would be PSC and ASC, but they're shield-shaped cataracts. Okay, the management is similar to vernal. You want to carefully monitor them for any other infectious complications such as staph and HSV. In severe cases where they're very uncomfortable, again, you may want to treat them systemically, even with steroids. All right, what do you guys see here?
It's a huge, almost looks like a plaque on the conjunctiva.
Yeah, it is a plaque. Woody appearance, that's it. That's the exact term. And we're talking about ligneous conjunctivitis. It's very rare. It's chronic. It's usually, you get this firm, woody, yellowish, fibrinous pseudomembrane, and it's adherent to the conch surface. You can peel these off, actually. They're not really sure what the etiology of this is. Some people think it's foreign body related. Some people think it's a severe deficiency of type 1 plasminogen, but we're not really sure what causes the ligneous conjunctivitis. But it can affect all ages. It's usually bilateral, causes irritation, foreign body sensation, and again, just like the picture shows, you won't forget it, yellow plate-like mass, and it's usually on more than one palpebral surface. It can come back after you peel it off. So how do you manage it? You want to definitely rule out an infectious cause when you see these, but you could treat these with topical steroids, Restasis. They say purified plasminogen concentrate if you think that this is a type 1 plasminogen deficiency. Surgical excision and cryotherapy, but recurrences are very frequent in these patients. It's very uncomfortable. Okay, we are almost there, ending. So this is a patient complaining of contact lens intolerance. Again, another picture just to sort of highlight these giant papillae, very different in size. You got the discharge right here in the furrows. And you get GPC in patients who have contact lenses, and there's probably a lot of mechanisms why, but usually they think it's from contact lens, the lid rubbing up on the contact lens, and especially in toric contact lenses as well. There's a suggestion of immune-mediated response, repeated mechanical trauma, hypersensitivity to the contact lens polymer, and significant dry eye can also lead to this type of GPC. It's especially seen with extended wear, causes redness, itching, mucoid discharge, less contact lens tolerability. So they come in saying, I can only keep my contacts on for about 2-4 hours a day. Don't forget to flip their eyelids because you may see this and it's definitely treatable before saying they can't wear contacts again. You may have a mild papillary reaction, but you can have giant GPC. So the GPC is a more severe end of the spectrum, and it's seen earlier and more frequently in soft contact lens wearers. They can cause blurred vision, contact lens decentration, again, just intolerability, redness, bloody tears, ptosis, and the signs are hyperemia, thickening, and abnormally large papillae. More than 0.3 millimeters is the definition. So the goals in the management of GPC and contact lenses is you want to resolve the symptoms and you want to be able to put them back in contact lenses. But first thing you tell them is to have a contact lens holiday. They need to be off the contacts for a few weeks. You need to reduce the wear, make sure that they're not overusing them, tell them that they need to have contact lens holidays. You may want to refit them, again, into dailies probably so that they're not continuously inoculating themselves with any kind of allergen. And you want to improve their lens hygiene and give them mast cell stabilizers. If they're going to be off contact lenses, you could do a short course of topical steroids. This works very nicely. I usually will start them on steroids and bridge them over later on to a antihistamine and refit them in dailies. Again, refitting strategies are daily wears, disposable contact lenses, sometimes even changing the contact lens name brand. You wouldn't think, but sometimes it's just having a different polymer there that makes a difference. And then, you can change them into RGPs as well. Another thing that you can offer patients who come in with red eyes and it's contact lens related is to have them clean that out with the hydrogen peroxide solutions, because a lot of times that will remove also some of the allergens and the excess protein deposits. Okay, and this is a 30-year-old. Now moving on, that was the immune-mediated conjunctivitis. This is a 30-year-old female who's complaining of dry eyes. What do you see in the picture?
Superficial limbal keratitis.
You got it. But to describe that exactly, you're going to see injection. It's usually superior. This already has been stained with rose bengal because that's the way that you would see this. And it's considered a dry eye-related disorder, and it's caused by mechanical trauma from the upper lid to the superior bulbar and tarsal conjunctiva. And we see this a lot in autoimmune thyroid disease. So when you see SLK, you've got to think thyroid. Aqueous tear deficiency can lead to this as well, and blepharospasm. Symptoms are usually irritation and redness. Clinical presentation is usually that's a chronic, recurring condition. It's usually adult women in the ages anywhere between 20 and 70 years old, usually in their 40s and 50s. It recurs over a 1 to 10 year period and usually can resolve spontaneously, but they're pretty uncomfortable and bilateral usually. So again, on the slit lamp findings, you find that you have a papillary reaction on the superior tarsal conjunctiva, you get injection and thickening, you get hypertrophy of the superior limbus, fine punctate staining of the superior bulbar conjunctiva and superior cornea, and filamentary keratitis. That can be, again, very uncomfortable and you should remove. The diagnosis is made clinically. If you were to take cytology or scrapings of this, you could, and you would find a lot of inflammatory cells in there. And thyroid function test, again, because you're going to suspect thyroid disease. The management is usually preservative-free tears. You can use cyclosporin drops, mucomist as well for the filaments. You want to remove them and then maybe put them on mucomist if it recurs. A large diameter bandage contact lens to prevent rubbing from the eyelid onto the superior bulbar conjunctiva. Superior punctal occlusion can help, and then they talk about thermocardialization of the superior conjunctiva and resection, actually, also of the bulbar conjunctiva, the superior bulbar conjunctiva. So that's it, guys. That was a summary. Basically, what we talked about was when you're talking about conjunctivitis, you want to divide them into different groups. You want to be able to tell what type of conjunctivitis is, because that's going to lead you in the right path. So you got papillary, follicular, membranous, cicatricial, and granulomatous. The infectious types that we talked about were bacterial causing, so blepharitis, an acute, hyperpurulent, gonococcal, chlamydia. And the viral were adeno, molluscum, hemorrhagic, the main characters. Ophthalmia neonatorum, which, like you said, was in your OCAPs. It's always in there, always. And granulomatous paranoids, ocular glandular syndrome, even though it's not very common. And the immune-mediated ones are allergic, vernal, contact lens-induced, and ligneous. I won't be talking about Stevens-Johnson. That's another lecture for you guys. And then the last one was SLK. Do you guys have any questions? That's it. We flew through those, but you guys did great because you guys were all ready for me.